Hi, everyone. My name is Rino Seedor. I'm an assistant professor of medical oncology at Thomas Jefferson University in Philadelphia. And so today I'll be talking about updates in skin melanoma. I have no disclosures or conflicts of interest. And since I only have 20 minutes, I will just be going over key updates in skin melanoma over the past year. I'll be talking about adjuvant therapy for stage 2 disease and some therapy updates in the metastatic setting. So talking about melanoma, it is a fairly common cancer. It's the fifth most common cancer in the population, and the incidence is rising over the years, although the death rate has stabilized. And when you're talking about melanoma staging, the T stage is based off of the thickness and the ulceration of the tumor. And then the N, the stage 1 and 2 is based off of how deep the melanoma is and whether or not there's ulceration, so the T stage. And then when you get to stage 3, we're talking about lymph nodes, but we're also including in-transit metastases and satellite metastases. So what are those? And so when we talk about microsatellite disease, it's disease seen under the microscope. And so when you're looking, the pathologists look at it under the microscope, we see the skin melanoma in the epidermal and dermal component, and then a little bit away from the cancer, we see another focus of cancer, and that would be considered a microsatellite tumor. And then satellite tumors are seen visibly within 2 centimeters from the primary site. And then in-transit metastases are melanomas that are seen beyond 2 centimeters. And so the field of melanoma has seen a lot of new drug approvals over the past decade, which has been really exciting. And so beginning with the approval of ipilimumab in 2011 and vemurafenib, we've really come a long way with immunotherapy checkpoint inhibitors, as well as BRAF/MEK inhibitors. And most recently in 2022, there was the approval for nivolumab and relatlimab, which we'll talk about. And so skin melanoma is typically diagnosed by a dermatologist by a skin biopsy. And then the patient will go to surgery. Whether or not they need a sentinel lymph node will depend on the thickness of the tumor. So generally melanomas that are greater than 1 millimeter, and if there's some ulceration, that would be considered something for a sentinel lymph node biopsy. And so they'll undergo a wide local excision with sentinel lymph node, and for some patients they're cured, but still do have a high risk of recurrence. For some patients, unfortunately, the cancer comes back or they've started out with metastases. And so when we think about therapy for melanoma, there is nothing FDA approved in the neoadjuvant setting, although I will say that there are several clinical trials looking at therapy in the neoadjuvant setting, and then that may be something that the field is moving towards. But currently in the adjuvant setting, we have for stage 2B, 2C patients, we have pembrolizumab approved, and then for the stage 3 completely resected stage 4 patients, we have dabrafenib trametinib, which is a BRAF/MEK inhibitor. And then for immunotherapies, we have pembrolizumab, nivolumab, and ipilimumab approved. In the metastatic setting, we have the immunotherapy drugs. We have 3 different BRAF/MEK inhibitor combinations approved, and then we do have a triplet combination. TVEC is approved, and then although TIL therapy, tumor infiltrating lymphocyte therapy, is not yet approved, I foresee that it will likely be a therapy in the future for melanoma patients. So going into adjuvant therapy, like I said, for stage 3 patients, these are the immunotherapies and BRAF/MEK inhibitor therapies that have been approved and the clinical trials that got them approved. And then this year, newly approved as of December 3rd, 2021, is the KEYNOTE-716 trial that got pembrolizumab approved in high-risk stage 2 patients, the stage 2B and 2C patients, which I'll go over. And just a reminder, stage 2 and 2B, so stage 2A to 2C patients, those are patients with melanomas just within the skin, but it is a deeper melanoma, a higher stage 2, and it may or may not have some ulceration. And the stage 2B, 2C patients only make up about 7% of melanoma diagnoses at presentation. And why we decided to look at adjuvant therapy for stage 2B and 2C patients. So this is the AJCC version 8 melanoma-specific survival curve. So if you look at stage 2B and 2C, the 5-year and 10-year survivals, you'll see there ranges around 75 to 80%, mid-80s. And then if you look over to the stage 3A, 3B patients, the 5-year, 10-year survival is actually a little bit better than the 2B, 2C patients. So if we have adjuvant immunotherapy approved for stage 3 patients and we know it's beneficial, then maybe we should be considering adjuvant therapy for stage 2B, 2C patients who may be just as high of risk of as stage 3 patients. And so the Keynote 716 study looked at resected stage 2B, 2C patients. They must have had a negative sentinel lymph node biopsy, randomized within 12 weeks of surgery. And this trial did allow for patients greater than 12 years of age and up. And so it did have some adolescent patients in the trial. And they were randomized 1-to-1 to either pembrolizumab 200 milligrams every 3 weeks for 17 cycles, which is about a year, or placebo for 1 year. If they did recur on this trial, they were able to be unblinded. And if they were on the placebo arm, they were allowed to receive pembrolizumab. Or if they were on the pembrolizumab arm and then later recurred, they may be able to re-challenge with pembrolizumab. And so this is just a reminder what checkpoint inhibitor therapy really is. So pembrolizumab is a PD-1 inhibitor. And so PD-1, PD-L1 is a checkpoint. And so the T cells, when they go to attack the tumor cells, if there's a PD-1, PD-L1 connection, that prevents the T cells from attacking the tumor cells. And so we are blocking PD-1 with pembrolizumab. And so this was published in the Lancet in 2022, the second interim analysis of this study. The median follow-up was 20.9 months, so not very long, but they did meet the primary outcome of recurrence-free survival improvement. And so the hazard ratio was 0.61 and the p-value was significant. The median recurrence-free survival has not been reached for either group. And the 18-month relapse-free survival for pembrolizumab was to 86% and 77% for placebo. And so there was about an absolute 9% benefit in relapse-free survival. The median treatment duration was about 11.1 months for both groups. And so most patients did complete all 12 months. This is the Kaplan-Meier curve for the recurrence-free survival. And as you can see, the blue line, the pembrolizumab line, is better than the red placebo arm. And this is looking at different patient populations. So regardless of the T category, age, sex, ECOG status, geographical region, pembrolizumab did improve recurrence-free survival compared to placebo. There are adverse events associated with checkpoint inhibitor therapy, and so about 18% of patients discontinued pembrolizumab due to a drug-related adverse event. Immune-mediated adverse events were seen in 37% of patients on pembrolizumab, although they were mostly grade 1 or grade 2 hypothyroid hyperthyroidism. There were some grade 3, 4 immune-mediated adverse events, 10% of them in the pembrolizumab arm. And when you look at long-term hormone replacement therapy, patients who did have endocrinopathies, hypothyroidism, adrenal insufficiency, thyroiditis, hypophysitis, type 1 diabetes, so most of those patients did end up having to take long-term hormone replacement therapy. So there is still some discussion of which patients we should really be treating with this adjuvant pembrolizumab, because the absolute benefit was about 9%, and we are putting patients at risk for long-term issues. And these patients are technically cured, and so we don't want to overtreat. And so we're still trying to figure out which stage 2B, 2C patients should really be getting 1 year of adjuvant therapy. Moving along to metastatic therapy. And so these are the immunotherapies approved in the metastatic setting. Nivolumab and relatlimab was newly approved as of March 18th of this year. But before I go there, I just want to go back and look at the update for Checkmate 067. This is a trial that was really game-changing in melanoma, in metastatic melanoma. And so this is the trial that looked at metastatic melanoma, previously untreated. They either got randomized to ipilimumab, 3 milligrams per kilogram, and nivolumab, 1 milligram per kilogram. And the combination was given every 3 weeks for 4 doses. And then you moved on to nivolumab maintenance therapy with 3 milligrams per kilogram. So just note that this dosing is, we consider this the full dose ipi-nivo 3:1. This dose is different from some of the other cancers where they may use a flip dose where the ipilimumab dose is a little bit lower. But in melanoma, we do use the 3 milligrams per kilogram dose of the ipilimumab. So that was the ipi-nivo arm. Other patients got nivolumab alone or ipilimumab alone. And this is the overall survival update based on ASCO 2022. This is the 90-month update, and this is very impressive. And so if you look at the median overall survival for patients who presented with metastatic melanoma, so melanoma throughout their body, they on average lived 72 months. In nivolumab alone, they lived 36 months, ipilimumab 19 months. So at 90 months, half of the patients were still alive with metastatic melanoma. And so this is incredible because before immunotherapy was approved, these patients were living months, less than a year for sure. And now these patients are living 7 years and beyond. This is the melanoma-specific survival. So if you take out the patients who died from other causes, 55% of patients who got the full dose ipilimumab nivolumab were still alive at 90 months. Progression-free survival, as you can see there, 11.5 months with the ipilimumab nivolumab arm, 6.9 with nivo alone, ipi was 2.9 months. The overall response rates you see there was highest with the combination at 58%. Nivolumab was still pretty high with 45% and 19% with ipilimumab. This is also very impressive. These are the patients who are still alive at 90 months. They looked at what treatments they got after ipilimumab, nivolumab, or ipilimumab, after their initial treatment, what they were still on. If you look at the very left pie chart, the red, 77%. So 77% of patients who got ipilimumab, nivolumab at 90 months, if they were alive, were treatment-free and had never received any other therapy. And so they had either come off because of toxicity or they completed the 2 years of the therapy and they didn't need anything else for 7 years. It's very impressive. And similarly for nivolumab, patients who were alive at 90 months, about 70% of them were treatment-free and had never received anything else. But we do have to remember that immunotherapy does come with side effects. And so it can come with all different types of autoimmune side effects. And if we kind of zoom in here, for ipilimumab, nivolumab with the 3 mg per kg ipilimumab, nivolumab 1 mg per kg, about 59% of patients had a grade 3 or 4 adverse event. So it is high. And then with just nivolumab alone, it was 21%. Ipilimumab alone, it was 28%. And so yes, this therapy is effective. It has long-term durable response, but it does come with a lot of side effects. And then now we're going to switch gears and talk about the new approval with the LAG-3 inhibitor. And so if you can look at the very bottom of the T cell, LAG-3 is down there. And so what is it? LAG-3 and PD-1 are often co-expressed on tumor-infiltrating lymphocytes, and they contribute to tumor-mediated T cell exhaustion. So LAG-3 is often found on exhausted T cells. And by binding with a LAG-3 inhibitor, we're hoping to activate the T cell and to help kill tumor. And so relatlimab is a LAG-3 inhibitor. In the Relativity 047 trial, it was combined with nivolumab. And so this was previously untreated metastatic melanoma patients who were randomized to either relatlimab 160 milligram and nivolumab 480 milligrams every 4 weeks. This was a fixed dose combination, as in this was one IV bag. And it was given every 4 weeks. And unlike the Checkmate 067 trial, where they gave therapy for 2 years, there was no endpoint for this. They continued to get therapy as long as they were benefiting from it and were tolerating it. Nivolumab similarly was given every 4 weeks for as long as the patients were tolerating and getting benefit. So the primary endpoint of the study was progression-free survival, and the median follow-up was 19.3 months. So again, not very long yet. And so median PFS was 10.22 months with the nivo-rela arm, and then nivolumab was 4.63 months. And PFS across stratification factors, nivo-rela seemed to be better than nivolumab in all different groups. And I'll stop here to point out that the LAG3 expression, they looked at, did LAG3 expression help predict whether patients responded to nivo-rela or not? And they seemed, both groups, regardless of what percent their LAG3 expression was, seemed to benefit. And so again, melanoma, there's no real biomarker to help us determine if immunotherapy will be effective or not. PD-L1 expression 2, if it's low or high, they still benefit from immunotherapy. And so we don't really have a good biomarker to tell us which patients actually respond to immunotherapy or not. Secondary endpoint, they looked at overall survival. The overall survival median was not reached for nivolumab or relatlimab at this point. For nivolumab, it was 34 months. The hazard ratio was 0.8 and the p-value was 0.0593. So technically it did not meet statistical significance. But if you look at the graph, it does look like there is some difference in the overall survival. And we'll see with longer follow-up. Overall survival, again, across different stratification factors, nivo-rela was still was better than nivolumab alone. When you look at overall response rate, it was 43% for nivolumab or relatlimab, and it was 32% for nivolumab. When you look at side effects, the grade 3-4 side effects for nivolumab or relatlimab was only 21% versus 11% in nivolumab. And so what do we do with this information? And so you're not supposed to compare trials to each other. You can't really do that. And that's partially because the patient populations are different. The designs of the trials are different. But if we do look at the two different trials and the different patient populations, the Checkmate 067 trial did have more patients with M1C, M1D disease, and similar, a little bit less patients with BRAF mutations, similar LDH high patients. If you look across the overall response rates, PFS, OS, again, you're not supposed to compare trial to trial because they are different, but the overall response rate, PFS, OS, is longest with ipilimumab, nivolumab. Interestingly, if you just look at the nivolumab monotherapy arms in the two trials, the nivolumab arm in the Checkmate 067 trial did better than the nivolumab arm in Relativity 047, and we're not quite sure why. And again, this is another reason why it's difficult to compare trials. But one thing you can take note of is the grade 3-4 side effects. It's 55% with Checkmate 067 and only 21% with the nivolumab relatlimab arm. And so that's something to take note. And this is the OS graph. The left one is Checkmate 067 and Relativity 067 is on the right. I think we just need longer follow-up with the Relativity trial because we have such impressive survival data in the ipilimumab nivolumab Checkmate 067 trial that I think we have to see if Relativity 067 really lives up to the benefit that we've seen with ipilimumab nivolumab. So shifting gears to targeted therapy, melanoma, skin melanoma, most commonly has a BRAF V600 mutation seen in about 38% of patients. And so BRAF is a serine threonine protein kinase activating the MAP kinase ERK signaling pathway. And so it's predominantly at codon 600 with a single nucleotide mutation resulting in a substitution of glutamic acid for valine. And so that's why it's called a V600E mutation, because it's a substitution at 600 for E for V. And if you look at the right, you'll see that this is the RAF-MEK-ERK pathway. And so when there's a BRAF V600E mutation, this BRAF is overactivated and this pathway is overactivated, which leads to cell proliferation and survival. And so we have BRAF inhibitors, encorafenib, gebrafenib, vemurafenib, which block this BRAF and subsequently inhibits the pathway. What we found is that patients eventually develop resistance to these because the downstream protein kinases, MEK, ERK, those get overactivated to make up for the BRAF inhibition. So now what we're doing is that we're all combining a MEK inhibitor with a BRAF inhibitor to try to double block this pathway and to inhibit cells from growing. And so there's 3 different combinations approved in metastatic skin melanoma. There are some differences between the 3 pills, the 3 combinations, kind of the pill, number of pills, whether it needs to be refrigerated. There is some nuances there. And the side effect profile is a little bit different, but in general, these are kind of the side effects we expect: fever, rash, photosensitivity, retinopathy, LV dysfunction, squamous cell cancer, keratoacanthoma. And it does have some relatively high grade 3/4 toxicity. But the good thing about BRAF/MEK inhibitor therapy is that patients respond quickly and the response rate is relatively high. And so you see a patient on the left in A, patients with a lot of subcutaneous nodules, but within 15 weeks of therapy, all of that was gone. And then C, unfortunately, after 23 weeks of therapy, the patient's nodules came back. And so yes, patients have a very fast, very good response with BRAF/MEK inhibitor therapy, but they often do develop resistance. But the question that melanoma oncologists always had was, if you are presented with a BRAF mutated metastatic melanoma patient, does it matter if you start with immunotherapy or does it start with BRAF/MEK inhibitor therapy? And so the Dreamseek study was designed to figure this out. And so we care about arm C and D, starting out with ipi/nivo first and then progressing to dab/trem after progression, or dab/trem and then switching to ipi/nivo. And so if you look at the overall response rate graph, arm C, again, starting with immunotherapy first, the response rate was 48%, and then BRAF/MEK was 30%. Grade 3 side effects were similar across the groups. And then the PFS and OS, there was a significant difference. It was much better with starting with immunotherapy first and then going to BRAF/MEK versus starting with BRAF/MEK and then switching to ipilimumab, nivolumab next. And so Dreamseek study kind of solidified what I think most oncologists were doing, but kind of proved to us that yes, starting with immunotherapy is the way to go for these BRAF mutated metastatic melanoma patients, unless patients have bulky symptomatic disease or visceral disease, or if there's a contraindication to immunotherapy, that may be a situation that you consider starting with targeted. But for most patients, start with immunotherapy. And so just to summarize, for primary melanoma, you treat them by resection. Some patients will get a sentinel lymph node biopsy with it. And then for adjuvant therapy, now adjuvant therapy is approved for stage 2B patients and above. And then for metastatic melanoma, ipilimumab, nivolumab has drastically changed the survival, improved it to a median OS of 72 months. And so that's why even with BRAF mutated patients, we start with that. And then Relativity 047, relatlimab, nivolumab is a new immunotherapy combination. We're still trying to figure out where this fits into the treatment paradigm. And so with that, I'll close. So thank you.